Thank you so much for watching TV 47. Time now for the People's Court. My name is George Maringa, of course, on the show with Victor Muyakane and Linda Alela. Now with me here as we discuss the universal health coverage at the backdrop of the launch by President William Ruto. Tonight I'm joined by Wycliffe Ogenya to my extreme right. He is Secretary General of CHESOA, that is Community Health Services and Development Officers Association. To my right here is Lillian Mutua, Head of Health Promotion in Nairobi County. Ladies and gentlemen, thank you so much for joining us. You can use your microphones for this conversation, and it is great to have you.
Thank you.
Thank you for having me.
Brilliant. Now, the launch yesterday by President William Ruto, Dr. William Ruto, came at the backdrop of so many promises, especially in the health sector. And I'll begin with you, Lillian, perhaps. From what you saw yesterday, of course, there have been feasibility tests. There have been, trials here and there. And what we saw as the culmination, do you think that perhaps this will be the ultimate, silver bullet in the journey towards UHC, having seen how we've grappled with healthcare in this country?
Thank you so much. What I'd say is that having been tested and tried, I think we are on the right path.
Okay.
And what we are doing about universal health coverage is also taking health the right direction. First of all, integrating health into community services and also helping the citizens understand that health is a personal responsibility as an individual, as a family, as a community, and then as a nation. When we look at health, we only don't look at health when people are sick or ailing. We start looking from when we are well, and we need to know what we need to do for us not to get like the communicable diseases, the non-communicable diseases. And looking at those two, it's a very high burden to the health services and nationally to our budgets.
Okay.
So when we strengthen the community health services and when we integrate health services to communities, then everybody has a role. The first role is about prevention. The second one is promoting healthy lifestyles. And then in case you get sick, we expect that you quickly access and utilize available, affordable, accessible, safe health services near reach. And where does this start? It starts from the community, then to the next level of facility, to the highest. Okay. And we expect to get optimum care. We expect to reduce our burden for budgeting in the curative.
Okay.
So we are squarely looking at preventive, promotive health, and also strengthening rehabilitative services and improving the care when we are in the health facilities.
Brilliant. Thank you, Lillian. And we'll come now to the merits and, deeper analysis of what, we shall be expecting moving forward. Wycliffe, I wonder, do you believe that, these people have been trained, your colleagues have been trained to the expectations that they require in terms of what they will be going to face and handling in the communities?
Thank you. I want to say that community health approach is very important for us as a country, and these are practices that have been tested across the world.
Yeah.
And if you look at the history of community health, or the community health approach as it were, you realize that it basically establishes the strengthening of the community health system, so ensuring the participation of the communities by making sure that they are well empowered, greatly would increase their participation in terms of seeking healthcare, and their training is very key for us. Why is that important? It's because that these people then would be able to provide services at the community level in the right and appropriate way, and thereby they'll be able to reduce diseases at the community level. So the step by the president and of course by the Ministry of Health to ensure that the community health promoters are well recognized, and also, of course they are facilitated by way of providing them with the kits, the tool they need to be able to perform this task at the household level, go a long way in ensuring that we reach we achieve the UHC as it were. Thank you.
And indeed, it is important to mention at this point that we have the kits here in studio, and Linda Lela will be taking us through, to see what we have and, to be able to see, what, happens now moving forward. But before we even cross over to the other side, briefly to you, Lillian, when you look at the numbers of these community, the CHPs, do you think it's a proper ratio to begin with, or should you even now proceed? Because it looks like the focus is more on, whereas, you talk about, preventative, but, this is, heading towards curative. But is it as sufficient numbers, as it were, because of the populations that you find, especially in a county like Nairobi?
We are saying that looking at Nairobi, most of our citizens in Nairobi are living in the informal.
Yeah.
That is 60% of our population is the informal population. 40% is the other population. When we are looking at the community health services, we are looking at these community health promoters taking care of households that are within reach. And these are people who are well conversant with their communities, people who are trusted by their communities, people who are respected within their communities and trusted, therefore. And why we say that it will work is what they are giving is not really medication, but the first point of care. In our community setups, even traditionally, you know that even traditionally we have our own caregivers within our households, but these people don't have enough information. These are not people who understand the referral pathways, so that, for example, if someone had an accident, who is the next person to be responding? It's that person at the facility, which is at the community, that is the community unit. So our services begin at the household, in the community, that is the level 1 of health services. Then we go to the other, which could be a dispensary, a health center, a hospital, and a referral hospital. So when the CHPs or the community health promoters are at the community level, if you do not know how to make a decision of whether you need to go immediately for attention in a hospital, this is someone who is within your community. You can always talk to them, ask them for advice, and let them know what you are having. Maybe yourself, a member of the community, a member of a household, and they'll be able to refer you and link you appropriately. Because they know, maybe if it is someone who has a broken limb, they know how they can do the first aid, maybe to avoid more injury to that limb, and they will immediately, like in Nairobi, call the emergency operation center, where an ambulance can be dispatched to the community. They can also be able to link with other administrative providers or other line sectors that can swing into action, because they are integrated not only to health but also the multi-sectoral approach. So it will be a very good game changer, where number one, what we are looking at is the affordability of health services, the utilization of the services, and access to the nearest facility. Because you find people go, even someone has a cough, they land in a county referral hospital at the waiting bench. Then there's another person who has come maybe with very severe illness or even an accident, who needs to be attended immediately, and this person would have been attended at a level 2, which is a dispensary, or a health center at level 3, and this person now is waiting in a county referral hospital. So they are also able to inform their communities, educate them, refer and link them. And they are also doing community surveillance for other diseases like polio, for TB, for malnutrition, and the rest.
Absolutely, and we'll be coming to you, Wycliffe, to look at more, the merits and demerits of it all, looking at the in-depth of it. But I want to throw you to Victor Muyakane. Victor, over to you. You have a guest, and, we look forward to getting their perspective. I want to hand it over to you, Victor.
Thank you, George. Good people, with me in my section of the studio, I have Dr. Amakove Wala. who's here with us. She wears many hats, but today she's here as a health systems strengthening expert, among other things. Yes. Karibu sana.
Thank you very much, Victor.
Right. Plain and simple. What we're talking about, the CHPs, the UHCs, all of them sit in a healthcare system. So paint a picture for us, for the viewers who are watching tonight, what a healthcare system should look like for a country like Kenya.
Yes, so in terms of the healthcare system, we look at ideally 6 pillars that are well defined by World Health Organization. And this means that if you're building a structure, if one pillar is missing, then the whole structure really becomes very vulnerable to collapsing. So in the health system, we talk about the people. So that's the human resources for health, including the community health promoters who are being kitted the other day, and which is a very great step towards ensuring that health, which is defined in WHO, is not just the mere absence of disease, but everything holistically, including mental health. Then the second pillar we look at is the money, so the resources behind the system. So healthcare financing, when you talk about the kitting of these community health promoters, how are we going to sustain the kitting of them? Or how are we going to sustain the referral system to the other health facilities? So that's, the money is really, really important. Then the third one, we're talking about the commodities. So this is what we use, whether it is in surgical, whether it is pharmaceuticals, basically the movable parts of the healthcare facility. And this is very, very important because as these community health promoters are going to the homestays, they need to have basic things, as I think my colleagues have mentioned, things that they can use to attend to situations well before they escalate to the other level.
So just to be clear, when you talk about commodities, you're talking about thermometers, bandages, medicine. Is that what you mean?
That's what I mean. Yeah, vaccines in the higher facilities. So basically the items that you use to get people better. Right. And then we talk about governance, and I think governance is a very critical pillar. Huge. And here, when we see political goodwill, that's part of governance, where we have from the highest office in the land taking up primary healthcare approach in terms of fixing our health system. I think that's a very, very positive attitude, because we do hope that political goodwill will follow, resources follow political goodwill, number one. Number two, also accountability. Yeah, we can hold our president accountable and say, look, you said you're going to kit this 100,000, they've been kitted. How are we going to increase those numbers? Because 100,000 is it's a good start, but it's not enough. And then we also talk about health information systems. So this is the data or the linkages between how this young woman who's pregnant in the household, how are we able to monitor that this young woman, the health the pregnancy is really progressing well using the systems. And I think what I like about this current approach is that we've moved away. Victor, we used to have books, ledger books this big, you know, and you can imagine, for records, yeah, both with the community health promoters and also at the health facility level. So digitizing this space is a game changer for us. And I think one of the things we really struggle is when you go to a facility, your health records are kept there. If you need to go to another one, you start all over again. So this is, the health information system is a very, very big game changer. So Victor, as I've mentioned, if those, and there are others who add research, because we have to learn from models that we've rolled out. For example, this model that we're rolling out, we need to have the baseline, we need to collect information during the execution, and maybe at the end of 1 year, we need to come back and say, did what we set out to do, what are we seeing? Do we need to adjust in one place or another? We get feedback from the community themselves, from the promoters themselves, from the facilities, from the public at large, because it's through that we keep on refining the model and keep on growing. So with that, you have a very holistic approach towards fixing or towards ensuring that your health system is running efficiently. Right.
Now, you've done an excellent job breaking this down and helping people understand what a healthcare system should look like. Yeah. Now, there's a word, you and I know this word, universal healthcare. but there's a lot of people that are still unfamiliar with this.
Yeah.
Would you care to give us, in a nutshell, with the context that you've created about what a healthcare system should look like, what then is universal healthcare?
Okay. So, Victor, I'll maybe correct you a bit. We talk about universal health coverage.
Please. Thank you.
Yeah, so care is the actual service offered. Then coverage is what are we offering. So the ideal, if you look at it in a cube format, you have the height, the width. So you have 3 axes.
Yes.
X, Y,
base,
yes,
height.
Yes. So you think of it in a way that you want to fill that cube as you go along. Ideally, I'd say that universal health coverage is a vision. Actually, no country has ever achieved it.
Right.
But so it's us progressing towards achieving universal health coverage.
It's aspirational.
It's aspirational. But you look at how do we ensure that we cover the most number of people in terms of healthcare services with the most impactful services and at a very or no cost to them. Because what we've seen, and I guess many of our Kenyans have experienced, one simple admission to a hospital can send a middle-class family to lower.
They say we're one disease away from poverty.
Exactly. And so what the government, because the government, according to the Constitution, the government owes you the highest level of care, including reproductive health care in the Constitution. So you as a citizen are owed by the government the best level of care. And this is why these activities are there, especially in the Kenya Kwanza Manifesto. We see them saying that they are going to achieve a very good level of universal health coverage. So then you identify what are the, and these are studies that have been done, so it's not rocket science. What are some of the very basic things that cost less money but have a very big impact? For example, during the COVID period, we had hand washing. Basically just getting people to wash hands. We saw a massive reduction in respiratory diseases, especially for the vulnerable, the less than 5 years and older than 65. We saw reduction in diarrheal diseases. We saw basically very many a very big impact just with one activity, which is telling people wash your hands and also cover your, get masks. So with the primary healthcare initiative, we are, I think more other governments or other regimes have focused a lot in the infrastructure bit, which is important. We do need facilities to take care of people. But if you look at the costs, effectiveness of putting up a facility, let's say to do CT scans or to do cancer treatment, vis-a-vis giving vaccines to young girls to prevent cervical cancer, the cost of offering vaccination or the cost of offering healthcare information through the community health promoters has been shown to be far much less, but with a bigger impact.
Right.
So with the government economists, health economists, this is what they do. Then they advise in terms of very basic steps or very basic campaigns that we can start with as we aspire towards covering. Not to say that people who have cancer do not deserve care, but it's more of the gradual or progressive coverage of populations towards getting them healthy at a very affordable or less, or not taking them into a catastrophic spending on health.
Right.
Yeah.
Now, now that we have this groundwork, this basis, we will be able to come back and delve a little bit deeper. But right now, I'd like to go over to Linda on the other side. And Linda actually has the kits that we were talking about that were launched yesterday, and with the wonderful uniforms. So over to you, Linda. What have you got? Or more importantly, who have you got? And what they have
let's just say this is where the action is. But I am looking at my watch and I'm thinking it's important that we sip a glass of water quickly, and then I come and introduce you to the gentlemen, or perhaps just to mention their names. Richard Muga, seated right next to me. Richard Muga is a community health promoter. He'll be telling us, what the journey has been like to get to this very level. But of importance, we also have Georgia Gitonga, who is also community health service coordinator. Before we get to the action, allow us to take a quick short break, and we come back.
Let's clear pimples. Step 1. Acne's Creamy Wash.
All right, welcome back to People's Court, and we get to that bit where we understand what the kits are all about. But even before that, allow me to once again acknowledge the presence of Richard Muga as well as Georgiades Gitonga. Gentlemen, thank you so much for creating time to be with us. We start off from this very point, and perhaps, Muga, I think you would take us, or just give us, or paint a picture in a nutshell of what the journey of becoming a community health promoter is, because most of the people will want to understand, are you trained? And at this very point, picking up from the conversation that we have had, it is evident that we could be having an idea of what a healthcare promoter does, but the journey to getting to becoming one.
Yes, a CHP is a trained personnel within the community who is being nominated from the chief's barasas, and you must also have the integrity that can prove that you can. You must also have that urge in you that you have that call to support the community in case there is any problem within the community. Yeah.
So it begins from a volunteer basis.
It begins from a volunteer base, and it is a call that comes from within a person.
Okay.
Yes.
So who takes you through the trainings?
After you have been identified by the community leaders, you are. We have community units where you are being allocated, and we have the CHAS, community health assistants, who take us through the trainings by the help of the sub-county coordinators, and the health personnel were well trained on health issues.
How long have you been doing this, and where do you serve?
I've been a CHP since 2012. Yes.
Oh, since 2012?
Yes.
That's quite like 10 years or thereabouts.
10 years back.
And still on voluntary basis, or there was some essence of payment?
On a voluntary basis. Yeah.
So officially there's good news.
The good news came some 1 year back.
Yeah.
When Sakaja came in, he decided to at least give us a stipend to support our work.
All right.
Yes.
Well, we'll be coming back to understand what exactly your work entails. Georgiades, thank you so much for creating time.
Thank you.
Upon that declaration by the president, of course, the good news here down to the digitization processes, to teaching them technology, up to this very point that there was the official declaration by the president yesterday. There's been some essence of disquiet within the other, healthcare promoters or workers, perhaps, at the level of the county, at the level of the community. What would it take for us to attain that aspect of synchrony?
Thank you, Dida. I want to take you back. Community health promoters didn't just happen like yesterday when the president flagged off the kits.
Right.
There's a Kenya Health Policy Framework of 2004. This one had indicated that there was a very big decline in the health indicators. Then the National Health Strategic Sector Plan 2 of 2005 to 2010 formed their community health services. And that's when now, previously they used to be called community health workers. subsequent regimes changed to community health volunteers because these are people who are volunteering the services to the communities. And now they are being called community health promoters. So these are people who have already been trained. They have been offering their services in their communities. Like my brother Richard has said, these are people who are selected or elected through the chief's barazas. Then they are trained. The community health promoters are not working in isolation. They are government-trained officers. These are community health assistants and the community health officers who are supervisors, who are immediate supervisors of the community health promoters.
Why do you suppose then this disquiet, these murmurs, these complaints, if these are people that have been in existence and the rest of the other practitioners understand their importance and the role that they play, and they equally understand the importance of us attaining a universal health?
The role of the community health promoter is basically preventive and promotive health care. They are not treating.
Yeah.
And like head of promotion, Lilian said, their basic role is preventive and promotive. We are trying to prevent, promote, and protect, according to the Ministry of Health. So there shouldn't be any disquiet. These are people who are doing preventive and promotive health care, and their summer date will be referral. Yes.
Okay, and perhaps to come back to you, Muga, to understand 2012
Yes.
up to this very point, just exactly what is this that you've been doing? No level, no essence of treatment?
Actually, our work is to advocate for health services within the community and to refer the clients who have become sick within the community. Again, we do follow up to the patients who have been treated within the facility, and maybe they are supposed to be followed back in the community. And we also do advocacy on health services which are being provided within the facility to the community, so that they have the information, and we also educate them on various health issues within the community.
With the understanding that health is a devolved docket, and perhaps that's why you say, well, thanks to Sakaja, there was some essence of stipends that you people used to get. How different do you suppose it will be now that there's an incorporation of almost all the counties, you know, in the process of making sure that at least there's something something small in terms of remuneration that goes to you people? So how different will it be, you know, from then and now?
Before we could do it willingly, but now that there is a motivation, I think we are going to, it is going to create a big impact in our communities.
All right.
Yes.
Okay, we come back to you, Gitonga.
Yes.
And yes, of importance is just how then is that aspect of synchrony. We're talking about devolution, we're talking about the national government being involved in this, but of importance, the understanding of exactly what the health promoters and the community health promoters are doing. Do you suppose there's this essence of conversation that has been there between then, of course, the health promoters at this very point when now we are pushing so hard to make sure that, well, they're well incorporated and the systems as to it, you know, with the rest of the other health sector stakeholders?
One of the things that I would laud the Constitution of Kenya is that it devolved the health sector. So health is devolved. I'll give an example of Nairobi County. In 2019, the former MCA for Zimmermad, Mr. Pius Mbono, brought in a bill called Community Health Service Bill Act of 2019, Nairobi County. Yeah. It was passed then, and Mr. Mbono had envisioned and he had seen the role the community health volunteers were doing then. And in the bill, there was a stipend of 3,500 shillings. And when the current governor of Nairobi came in, he operationalized that bill, and that's how the community health volunteers started getting their stipend. So when they were working without a stipend then, there was a lot of drop-off, as in most of the community health volunteers would leave this work out. But currently with the payment of the stipend and with the support of the partners, we are seeing an increase of community health volunteers who are coming back and they are getting trained. Going back to your question, are community health volunteers trained? Yes, they are trained. Remember, the Ministry of Health is a policy maker. Yeah. There is a basic module for community health volunteers. This is a module that has 6 modules that the community health volunteers need to be trained before they go out there to give services in the households. Then after that, there's a technical modules. There are different technical modules that these community health volunteers get trained on. There's a water and sanitation and hygiene module. There's ICCM, integrated communicable diseases. They get trained on communicable diseases. They also get trained on family planning and many other modules. So basically these are people who are trained and they are able to understand and also to know when to refer from the communities to, remember the communities, excuse me, remember the communities, the one service provider of the health sector. Then they're able to refer to the level 2, which is dispensaries, and they can also refer to level 3, which is health facilities. From there now, it is the role of the health facilities to refer to level 4, which is the county health facilities, and then the county health facilities, they are able to refer to the national referral system. That's the system of the community health service.
All right, and like you rightfully say, it's the role of the ministry, and we've also seen them trying to accelerate plans to, make sure that we get into the space of digital, and I think you've heard Dr. alluding to the importance of that. Just how far are we in terms of making sure that these health workers then, are tech savvy, are introduced into the world of technology and trained proper, and just how much is technology involved in this process?
The universal health coverage, currently with the flagging off of the community health promoters kit, maybe the media were not able to know that the community health promoters were trained on the electronic community health information system last week.
Yes, that is well known.
Yes. This is how now once they go to the households, they will be able to report using their mobile phones, and the government has provided that for the mobile phones.
Okay.
And they have an app, the electronic community health information system, that they're able to get information from the households and register the households, and even the referral system is happening through the phones. Yes.
All right. Quickly walk us through this, maybe not in depth, but perhaps just tell us what are we seeing on set?
Yes.
Come to now the in-depth.
Yes, before us are some of the kits that we were provided for to help us make our work easier when we are providing our services within the community. With me here is the weighing scale.
Okay.
This one is for weighing children above 5 years and above. And another weighing scale of the same work. And here we have the BP
Lift it
machine.
up so that people can see, yeah?
Yes.
We know what it
This
is.
one, yes.
This can
Yeah.
be like this, yes? Yes.
And with me here is the BP machine for measuring the pressure. And with me here is a flask where I can carry something.
And you don't want to open it for us to see. Some people would see you coming to them something that they are not aware of.
Yes.
And they start questioning. So a flask
Which I can carry water to drink when I'm on my duties within the community.
All right.
And here is a tin to help me carry some medication while I'm going to the households.
Okay. So medication is given to you by
the facility where I'm attached to.
Okay.
And here I have the glucometer for testing the sugar levels.
Okay.
The diabetes patient within the community. Again, I have the sharp box where whenever I've used my glucometer, I can keep my sharps here so that I can dispose them well within the facility.
All right.
And
that's a
flash spotlight, which can help me at night when I'm called for the services at night.
Okay.
We work 24/7. Whenever the community has known that you provide the services of as a CHP within the community, you can even be called at night when a woman wants to get services, even for maternity services.
Okay.
So we can use spotlight at least in the streets where there are no lights, security lights. It can support us.
Okay.
And we have the alcohol swaps. And here with me is a package of first aid kit with several things inside.
Okay.
It is good I show you. Yes.
Okay.
It has got several things.
Okay, the basics.
Yeah, the basics. The thermometer.
Okay.
The thermometer. We have the plaster tips.
Yeah.
We have the alcohol swabs, the sterile ones. And with me here are the MWAC tapes for identifying the malnourished children within the community. And I have even the bandages.
Okay.
In case of any injury within the community, we can do first aid for the injured one as we refer them to the facility for further services. And the cotton wool. Yeah.
Okay.
To help us when there is any injury within the community. Yes.
All right, so every health, community health promoter is equipped with this?
All the community health promoters are equipped with this.
Okay.
Yeah.
We're coming back to you, gentlemen, shortly. Allow us to go back to George. George, I'm sure you must be having reactions to the same. And so we'll come back to you, of course, and understand some more in relation to at what point are you on duty? Can you do something else and at the same time, just be a promoter, or you are there and attached fully? But George, to you.
Thank you indeed, Linda, and a wonderful illustration by the CHP there on what to, is in these kits, because you did see they were launched yesterday, and indeed, some development and some growth that we've seen. I'm still here with Lillian Mutua, Head of Health Promotion in Nairobi County. We've seen, as well as Wycliffe Ogenya, Secretary General of JESWA. Lillian, you've seen, what has been displayed over there. Of course, these are, items and kits that you're familiar with. But at the deep end of it all, and at the end of the day, these CHPs are people who eat, they live in homes, they have families to cater for, whereas they have volunteers. How about their payments? Because this, being able to meet their daily needs. Talk to us about that.
Thank you. Just like Muka has just said, the CHPs are more of volunteers within their communities, and giving them what we are looking at, that is 3,000 at the end of the month, and with the promise of our Excellency, Honorable Sakaja, he said that he is going also to give them some medical cover so that they can also get quality services when need arises. But as volunteers, it's not only about the 3,000 shillings.
Okay.
Wycliffe and Gitonga will, and even Muga himself will agree that for Muga to have worked as a volunteer from 2012, not only being co-opted into the medical services, he's undergone other trainings. He and other volunteers within Nairobi have undergone different trainings on entrepreneurship, on financial management. Some of the volunteers have come up with self-help groups. Some of them have even registered CBOs. So there's a lot of even strengthening as individual, as groups, and we've even seen them do some very excellent work. There are those who have joined groups, they do catering. You can hire tents from them. You can hire even the public address systems from them. So they are empowered not just to be the way they were as volunteers when they were coming in, but to look at different skills, different capacities, and also help support and guide them towards a certain direction. We have those who are also a bit not very young, people who are maybe being selected to be CHVs at even age 40, age 50, because that is the person that the community trusts most as their community health volunteer. So we can see that these are people who are even influencers within their communities. They are decision makers for their communities. At times people look at the community health volunteers as a lowly person. They are not. We even have religious leaders between them. We have people who are working in maybe the small, the industries. We have people who are SMEs and they are still volunteers. So being a volunteer, being a CHP, is not a lowly person, but as Muga correctly put it, it's a call. Maybe you aspired to be a doctor, your grades didn't allow you to.
Okay.
Maybe you aspire to be a nurse or to be a medical technician and you are not able because of one reason or another. But once you get that opening coming up, we've seen some of them come up with very excellent, innovative ideas in the community.
Yeah.
Some support excellent support groups, like for people with hypertension and diabetes. They've put the young mothers or women of reproductive age
Yes.
into support groups for breastfeeding, for nutritional advice. So they are really bringing up that promotional aspect of health within communities. They work very closely with the schools. They work very closely with the churches. So it is a whole spectrum of health in the community.
Okay.
Thank you.
Indeed. And Wycliffe, before we get to there, I'm even seeing feedback from Mutuku Fred on X saying, hashtag Afya Nyumbani will work with CHPs like Muga and CHEWs like Gitonga and Wycliffe. Hashtag Daily Report. We thank you for your feedback. Keep it coming. Wycliffe, when you look at now because your body, your association is sort of a supervisory role. When you look at the training, whereas this is volunteer work, at the end of the day we are looking at quality, universal health care. And at what point do you then distinguish that perhaps when someone shows up in the event of offering their services as a volunteer, they understand that perhaps in this community, in this household, patient X, like Lilian Mutua here, may have issues with tablets and medicines that have sulfur, so that then you do not end up even causing more harm, to be able to understand completely the broad healthcare needs that communities that they serve in have.
Okay, thank you for the question. I'd want to say that in this space of community health, we are looking at preventive,
Yes.
promotive, largely. So we are not focusing on curatives. It is important to note that communities have the innate capacity to handle their health issues.
Okay.
And as such, there is something that is already happening at the community level. If you go across communities, what the government is trying to come up with is to be able to ensure that whatever it is that is happening at the communities themselves, they are empowered, they have the capacity to be able to handle those, and that is why we have trainings for community health promoters.
Okay.
Like has been explained by one of the panelists, is that we have the basic training modules, and these basic training modules, you have 6 modules, and one of them is just to be able to introduce concepts in health and development. We are looking at issues of leadership and governance. We are looking at communication. We are looking at whole issues of health promotion. We are looking about basic health care and life-saving skills. Like, let's say someone has been bitten by a snake at the community level, and you're looking at a very remote rural area. There's something that the communities basically ought to do without endangering. And then when you look at the technical modules, the issues of water and sanitation hygiene, you are looking at, if you can all go back to the COVID era or the 2019, 2020 for us,
Yes.
you'll be able to see for sure we had interventions such as hand washing that reduced so many cases of disease at the community level and at the nation at large. So what we are saying is that we are having people who are trained to be able to handle issues at the household level, and that their focus is not going to be curative. So any other case that they are going to, for example, if you're looking at screening for nutrition at the household level, if we find that there's a child under 5 at the household, then they are referred to the facility.
Okay.
If there are cases of diarrhea, communities will be able to know that this child has had 3 episodes of diarrhea of passing loose stool within 24 hours. And as such, the household is empowered that they can be able to prepare ORS for them, and then once that has been done, then they are referred to the health facility. Remember, there are facilities that do not operate at night,
Okay.
and they are in rural parts. So if nothing is done to this household, then it means that we have a possibility of losing a life here. So the focus should be for us ensure that we offer preventive and promotive health services. Again, community health promoters are not working in isolation. they're community health officers who are well trained,
Okay.
and they're the ones who are able to supervise how community health promoters deliver their services at the household level.
Yeah, briefly, then that would mean that perhaps as they go to these communities, do they go as a group, or, ideally, or, how would then, would I expect someone to show up, in my house?
Individual community health promoters have been assigned 100 households.
Okay.
And in these households, they'll be able to visit this household based on the schedule that the household be available.
Okay.
But the community health officers have one of the key deliverables for them is to be able to conduct supportive supervision. So they'll be able to select given households within the time agreed with the community health promoter and be able to sit in to be able to see how they're delivering those services. But also we have group supervision where community health promoters would sit with a group of community health officers would sit with a group of community health promoters to be able to take them through what is required of them at the household level.
Okay.
And then I just wanted to weigh in on the issue of the stipend.
Yes,
I believe that Nairobi County is doing very well with regards to payment of the stipend. It is 3,500. The 500 is inclusive of NHIF currently. We've been able to see in terms of reporting rates, they have increased. We have low attrition rates currently. And we also know for sure that in Nairobi County, no county employee is paid before community health promoters are paid. So the governor, His Excellency Governor Sakaja, has made a deliberate effort to ensure that CHPs are paid ahead of the rest. I also know that the president was, during the launch of the kits, he committed that the national government will be able to match a shilling for a shilling. So if the county, for example, the county of Nairobi is giving a stipend of 3,500, I believe that the ministry will also be able to chip in with another 3,500, and this will go a long way in ensuring that we motivate the community health promoters. The other thing that we are probably also looking at is in terms of having a career path for the community health promoters.
So that it doesn't end with that.
Yeah, so that some of the community health promoters would ideally transition into even becoming community health assistant and community health officers. We are aware Nairobi County has 50 community health promoters who are already trained at Kenya Medical Training College through the support of the Ministry of Health. And I know that they will be able to get priority in terms of employment. When we are having employment for community health officers and community health assistants, they'll be able to get priority. And I want to just say, because of the nature of the association, we have the national, we know that 1,200 community health promoters were funded by the Ministry of Health to go at KMTC. So we are talking of people who are well trained. We are talking of people who are well supervised and supported to deliver on their mandate.
Because training and the skills is what was the. You want to chip in?
Yes.
30 seconds, please.
Yes, and I would also say that we now have the primary care networks that are being established in the 47 counties, and the community health promoters come in very handy because they are registering not only household, but also the individuals, and also looking at the financial capability within the household. So they are really coming in handy, and they are also part of the strengthening of the referral and linkage to services throughout the 47 counties.
Yeah, Victor, I mean, a lot is coming from this side. Remember, these are the community health, we have the Lillian, who is head of health promotion in Nairobi. I mean, these are some of the issues that we're hearing coming out, and we've also heard of the stipend, the trainings that are coming in. I wonder what from your end you may have, even as we enter the home stretch of this conversation.
Yes, indeed. And can I just say, our guests tonight have given us a rather comprehensive perspective on the subject matter.
Absolutely.
And I hope the people at home appreciate this. I hope this is exactly the information that you need to help you. Thank you.
Absolutely.
Dr. Wala, what's your take on what we're hearing this evening on CHPs?
I will come in, Victor, with a feminist lens.
Please.
The face of the community health promoter is largely female. And for the most part, they've been volunteers. So I think for this, it is a step forward also on the empowerment of women, because not only do they do this work, they also have households to run, they have businesses to run, or whatever other activities of daily living are. And for them to do this for, you've had a number of years, for all this time, and they're working 24/7, you're on call basically. I think without that motivation, we are doing a very big injustice to them. I just want to refer to International Labour Organization that talks about the care economy, and community health promoters are part of the care economy. And they have 4 R's that one is to recognize care workers. So the recognition that my brother Chesoa is talking about is the associations, the CBOs, basically the formation where they're able to speak and their voices are heard. So that's very, very important in terms of the care economy. The second one is redistributing labor. And redistribution of labor is, we've seen very well about the kit. I mean, now they're able to have digital records, they're able to carry out simple diagnostics with the equipment right on the spot. They're able to refer appropriately. So that makes their work lighter. They have a torch, something as simple as being able to see at night, we take for granted. Right. Yeah, and then we talk about representation and recognition and redistribution of labor. So I think in all this, we are not only getting to a step forward in universal health coverage, but we're getting towards women empowerment, we're getting towards meeting the needs that are there within the care economy. So for me, it's great news. I just have hope that we are going to do much more than 100,000. I think Chesoa needs to tell us how many community health promoters are needed in terms of data.
By the way, why don't we ask real quick, can you tell us exactly how many people would be ideal for this sort of work? 100,000 clearly is not enough. How many people would be ideal?
Basically, I would want to say that in the country, the Minister of Health is more competent to be able to respond to that. However, I know that the coverage, as we speak in the country, is about, with regards to community health units, about 90%. So we are looking at probably 10% more. Okay. And remember, the 100,000, you'll multiply that by basically 100, because each of the community health promoters is in charge of 100 community, households. So if you do the math, then you'll be able to
10 million.
Yeah, so that is the coverage we are looking at.
All right. Thank you for that. Now, had you completed your point?
Yes, I had.
Yeah, go ahead.
Yeah, and remember, we are talking about a dwelling. We are talking about a dwelling unit. Okay. So within that dwelling unit, there could be, if let's say working with an average household size of about 5. So you can imagine what we are really talking.
Okay.
about.
Yeah. All right. Thank you for that. Now back to you, Dr. Wala. You there's a concern among some people that with our health system, with some weaknesses in the areas that we have them, that there might be some abuse on the whole framework of community health promoters, in the sense that if you live in an area where the nearest health center is not so near, then this first line of defense now becomes a whole lot more than just that. Sure. Do you see that possibility?
The possibility is there, for real, but I think we've been taken through the process that our promoters go through to be certified, so to speak. There's quite a lot of training. And I think the big thing, again, is not to think of community health promoters or the primary healthcare networks in isolation. Remember, we still have the other pillars. We still have the facilities. We still have the other human resources. So I think it's not the magic bullet, but it's a very big step forward in terms of the priorities and the expenses that are required to fix our system. So Unless we have a very bird's eye view, there's always someone who needs to have that bird's eye view, such that as we're strengthening the best, the apex is also getting strengthened. The other thing is, I think he has mentioned, is supportive supervision. So again, these are not qualified, so to speak, health workers by themselves. They're just the first line of defense. And so within their training, they're trained to know to what level, because there's some intervention that you can, push that does more harm than good. So I think with that particular training, with refresher trainings, with feedback, with those...
And to know when to refer up.
Exactly. And just the fact that each of them is under a community health a CHA or an officer who's overlooking that. When we get that system working, then we do not have to fear about the abuse on the bottom.
Fair enough. Now, you, among many other things that you do, you actually are a health systems strengthening expert.
Sure.
Real quick, our health system, where are the gaps? Where are the areas of weakness? And therefore, what needs to be strengthened?
Our health system has a lot to be fixed. I would say that we've done a lot in the past. Devolution has made a remarkable difference, because there are some counties that really did not even have a surgeon to perform, not even a surgeon, a basic medical officer who's able to perform a simple cesarean section, which is a basic surgery to save the mother and child. And after devolution, we've had, especially with good governance in many of the counties, we've had them investing in different things. I think what we need is to reevaluate and not to be afraid of putting our resources behind things that are not as, let's say, very flashy. Like launching community health promoters is not the same as where you have your name on a ward, on a plaque.
Right.
Yeah, and I think primary healthcare has a lot of those non-flashy kind of interventions where as a leader, you do not have a legacy in terms of, this is the building that I
bears
put up.
my name.
Exactly. Yeah. And I think once we start moving away from very emotional and razzmatazz of that, yes, and we focus on the data, and the data, it's very important to understand what basically can move us from one step to another. But I think, in my opinion, one of the biggest weakness is the management of our human resources for health. And that's why we are seeing, at least this is a step forward in terms of recognizing and rewarding the work that community health promoters do. But we have the other cadres of workers. So we can strengthen this. We forget those ones. When you send our women to labor in a facility, we do not have enough nurses. We do not have a doctor to manage. And so we have a lot to cover. And I think I've seen in their manifesto for Kenya Kwanza that there's supposed to be a body, whatever form it will take, because a commission would require constitutional change.
Right.
But there's supposed to be a body that will help us with managing and developing our human resources for health. I think once we prioritize our people, a lot of the other things will follow course. Thank you. All
right. So talk to me about the next 4 years, for example. Unfortunately, in Africa, we think in election cycles as timelines for projects and all that. Talk to me about what you would like to see to be done differently. Talk to me areas of improvement that you'd like to see, particularly in those areas that you feel are very, very critical to offering universal health coverage for our people.
Victor, so one of the things I'd like to see is that we follow our strategic plan. In our country, we have the medium-term plans, and they're very well done in terms of, at least to the extent of the skills that we have. What we unfortunately see is that with every regime, we have a very flashy campaign that comes up. Everyone wants to be named. And this is not just at national level, but also at county level. So whatever the other leader started is dropped. Like we had the Big Four agenda.
Right.
We've forgotten about the Big Four agenda. Now we are getting into another manifesto with another government. So if we are able to stick to the very well-led plans that are supposed to take us to Vision 2030, I think we'll be far much better off. We may fashion it in whichever way, but at least follow a bit of that. Then the other thing is, as a country, Kenya, because I've been in this space for 18 plus years, we have enough documents in that Ministry of Health, in the county government.
Proposals.
Policy. Yes, all these are very well done. How do we implement it? Excuse me, because that is where I see the gap, where we have documents, someone else will come and say, okay, we need another document. We've not even implemented this particular document. So if we were just to get 30% of what we put down in those documents, we would be far much ahead, because we are not discovering something new. Community health promoters have been there in whichever term that they were being called before. We just need the political goodwill and the resources to follow the best laid plans that we already have.
Right, and just before I let you move to Linda, there's a concern among a lot of people that a lot of the key aspects of our healthcare system are actually donor funded. And then that reliance is causing problems. I think a couple of years ago we had an issue with HIV medicine. We had an issue with some vaccines and so on, with donors. Where do you stand on that? And where should we go in that regard?
So we signed the Maputo Declaration very many years back, which was to commit 15% of our GDP to health. I think we are at 6%, going to maybe 7%, depending on what you count. And unfortunately, most of that is exactly donor-driven programs. The thing with the donor-driven programs, they're good, but they come with certain restrictions, and they're very perpendicular, they're very silo-based programming. For example, you get money that's purely for HIV and AIDS, and you forget that this person with HIV and AIDS may be pregnant. So who takes care of the pregnancy part? And then you find even the training that our workers are given would be so focused on that, because that's what the donor said, this is where the money should go. I think we have a lot to go in terms of domestic resource mobilization. And this can come in various formats. It can come in actual government allocation towards health that will be met at 15% as we signed up. Only Rwanda in Africa has gotten to that 15% declaration, and Rwanda is doing amazing work because they started bottom up. The other thing is, how do we leverage on some of these taxes that you're already collecting in order to put it in a social health insurance fund? I think I've seen some bills circulating about us moving towards a social health insurance, and it's a great step. Execution will be another story, but it's a great step forward. Where do we get these extra resources? Things like syntax, things like,
right.
Yeah. So we can, and the biggest thing, Victor, is sealing the holes of corruption. If we just did that and forgot about syntax and forgot about all these levies that were being labored upon us, if we just seal the holes of corruption, we would take a very big leap forward.
Brilliant, brilliant. And as we digest that, Linda, what have you got for us?
Muga,
Yes.
straight to you.
Yeah.
Step towards the right direction, perhaps the right step that we could have made.
Okay.
What do you suppose the difficulties that still are underlying, and how best would you propose they are addressed? Because this is a good one, but yes, there's still more that perhaps needs to be addressed until we're there.
In terms of
Generally, how the community receives you, how you as well work with the rest of the other health practitioners, just the synchrony. What are some of the things that you'd want made better in as much as we have done this?
Yes, the challenges are still there. Maybe in terms of the welfare of the CHPs.
Mm-hmm.
If at all we could get the best support in terms of their welfare. So currently, if our welfare can be taken care of, then at least it will be a plus on our side. Again.
How was it like during the COVID-19 times? How was it like during the COVID-19 times?
It was a little bit hard, but due to the fact that I told you before that it is a call within us, we just find ourselves fighting together with the healthcare workers. Again, there should be much of education in terms of our work in the community, because most of the community still believes that CHPs are there maybe to to get funds from the donors through them. So if much of the education can be done, formal education can be done to the community members, so that they can know that our work is just to help them, not using their name to gain something.
Could there be a handful within yourselves that have tainted the image? And what are you doing to make sure that within yourselves then, that this is known to the community and that there are no those ones that are actually tainting the image to this point?
I think most of the health issues came up with a lot of donor funding, especially in an informal areas. So it tainted the work of the CHPs, that maybe they are being supported through helping the community members. But currently we are doing through the support of community health assistance, we can do some activities within the community that do much of education to the community members to help them understand what we are doing. Like we normally have the action days where we can identify an issue maybe which is affecting our community, and we go around as we clean the community around, as we make them understand that we are just there to support them have a better health within the areas where they're living.
How much of support are they getting? And we're coming back to you on that. Now that you're amongst them, you know, as the directors or the people who are making sure that this then runs proper, how much of support do they get, and how much more can be done towards, you know, making sure that, well, they're comfortable in terms of the concerns that they're raising?
Excuse me. I'll take you back. You asked a question about 2019 during the COVID era. The community health promoters, then they were used to be called community health volunteers, played a very critical role in preventing the spread of COVID. They also helped us as health workers in identifying and following up the defaulters in their homes. Remember, the community health promoters, these are people who give key messages in their households.
Yeah.
So they were more better off giving out key health messages, especially preventive and promotive healthcare. It is easier for someone like Mr. Muga here to go in their unit and give key health messages and be understood and be accepted than if, for example, I go and give the key messages.
Yeah.
So what the government did then, and they are still doing, is they equipped the community health volunteers then with PPEs, and they helped us in following up the community, the defaulters then of the COVID-19. Currently, the government has invested so much in training, capacity building the community health volunteers. I'll give you an example of Nairobi County. They have operationalized the community health desk, which is manned by a community health promoter. And if a client or a patient is referred from the community health unit, the first person they come to the health facility and meet is the community health promoter, who is at the community health desk. This community health promoter is able to guide this client or the patient to whichever services that they want to receive. Remember, the key goal of universal health coverage is strengthening the relationship between the communities and the health facilities. So that one has really worked, and I want to say a big thank you to the governor currently for doing that and for giving a stipend to the community health volunteers.
I realize that devolution plays a huge role. So when back then there were volunteers, today there is that official declaration that now they're integrated in the system. I have hosted a couple of them who used to say that, well, I am doing my usual job and then I am also doing this. How different is it going to be this time round?
Some of the talks that I've seen is the stipend is very low. I agree with the current economic status. They did a top-up, and the president made a declaration about that. Remember, the community health volunteers, they don't work full-time. They work a few hours, and other hours they are able to do their day-to-day activities. And coming back to the universal health coverage that was flagged off yesterday by the president, especially the kids, the training, as Dr. has said previously, the community health volunteers, remember these are people who go to the households and they get, they are checking health status of those households. Especially, we have different indicators that they are checking. One of the key indicators that the community health volunteers are looking out is, are these household members accessing any medical insurance cover? If they are not, then it is the role of the community health volunteer to encourage that household head or the household member to go and get a NHIF. So with the NHIF, if this household member gets sick, then they are able to access affordable, cheap and quality healthcare from the different health facilities that are within our county and all over the country.
All right.
Yes.
So you can do what it is that you do on the side, but at the same time handle this.
Yes, being a CHP is not an unemployed
job.
A full-time job.
Yeah.
You can just continue with your daily activities. That is why we are being attached to the household within the areas of our jurisdiction where we live.
In the event that you move, perhaps to a different county, to a different sub.
In an event where you move to a different county, because we are being issued with the certificate to show that you are a trained community health workers, you can still provide that service at the area where you have moved to. But when specifically they are being appointed from the areas where they come from. So it is not, after you have registered your household, we have the MOH tools that we use. But currently they have been reduced so that we can do them even using our phone. So, we have the MOH tools that help us identify the members who are living around the areas where we are. So after you have identified the members and you've known the health condition that is happening, whenever there is any need or call, you'll just find them calling you so that you reach at them very fast as you just continue with your day-to-day activities.
All right.
Yes.
The goal is to promote preventive and promotive health care.
Yes.
What will it take for us to get to that level if, well, the very same ones that are right on the ground and not full-time, what will it take for us to get to a point where the community will understand that you don't have to wait until you're sick, so that you go and get access of healthcare services? What will it take for us to find solutions to these concerns that have bedeviled us? Of course, not forgetting the numerous challenges that we have in the health sector.
One of the ways that we are going to get there is, remember these community health volunteers, much as they are not working full-time, they have households. The policy currently states that every community health promoter should have at least 100 households. In Nairobi, we specify that every month, the community health volunteer should visit at least 33 households. And remember, there's a tool called MOH 514, which is a community health volunteer service delivery logbook. Currently, now it has been digitized into the electronic community health information system. So wherever they are going to these households, they give key household information. And there are different indicators that they are picking. So within a span of 3 months, every household will have received preventive and promotive health care messages from the community health promoter. Yes.
All right, incredible. George Baringa, time is moving very fast. Back to you, so at least we can get the parting shots of your guests before we close it.
Absolutely, and indeed, pertinent points that have been raised are important and valid, conversations that we are having. And I could see my guests on this end. I'm still with Wycliffe Ogenya. Perhaps I'll start with you. I could see you nodding, to some of the reactions and the remarks that are coming from the other side of the studio.
Okay, thank you. I just wanted to emphasize in terms of what the community health promoters faced, especially during COVID-19, we realized that there was some gap that probably needed to be fixed. And currently, with the kids, we are already seeing that. That is the personal protective equipment for the community health promoters. Largely, most of these were being procured for healthcare workers, but in most instances, we probably kind of forgot the community health promoters. Then there is the other issue that Muga spoke about with regards to funding. So community health has been largely funded by the donor partners, and we are happy that now we are seeing a scenario whereby the counties the Ministry of Health is ensuring that they are able to bring funding, and that will be in good direction. Again, with regards to reporting tools, we have been told about the electronic community health information system that is being launched. Currently, we have counties that have trained. Almost all counties have had sensitization with regards to this. And then I wanted to say that for us to be able to enhance supervision for community health promoters, it's also good to ensure that we have a good ratio for community health officers and community health promoters. Currently, we have about 3,500 employed across the country. We still have a gap of about 6,500 community health officers that need to be employed. So we are looking again at the bills that are coming up in Parliament. We are looking at the PHC bill, that is the primary healthcare bill, and we see this is will also entrench the legislative framework for us to be able to achieve the coverage.
Your closing remarks?
I think I would say that we would really encourage the government that given the trajectory they are taking, we need to put in more money to be able to support community health services in the country.
Okay, so thank you very much, Wycliffe Ogenya. Lillian Muto, you get the last word from this side.
I just encourage the community also to protect the community health promoters. We've seen incidences where they go to work, and especially even at times when we are doing the campaigns, we find that their phones are snatched. At times they are requested to give away their bags, their own personal bags that they are working with. We ask the community to protect the community health promoters because these are their own people within their communities. Let us not vandalize whatever kits that they have been given. Let us also be able to secure their spaces when they are working. We remember that their biggest role is to protect the community's health and protect the community's health.
Absolutely.
Together we can. Tomorrow, it could be you who is ailing or me. So let us take up this good mantle that they have been given, run with it, and ensure that our universal health coverage gets its space and we can improve the quality of health within households, for individuals, in the institutions, in the communities, and as for all of us as a nation.
Absolutely.
And that will bring our
Thank you.
health bills down, and we will be going the right direction.
Absolutely, Kenyans, you've heard it. Please do not harm or bring harm to the community health promoters, the CHPs. I've been speaking to on this end Wycliffe Ogenya, who is the Secretary General of CHESOA, that is the Community Health Services and Development Officers Association. Thank you so much, sir, for speaking to us, as well as Lillian Mutua, Head of Health Promotion in Nairobi City County. Thank you, ma'am, for joining us. Victor, over to you.
Thank you, George. Dr. Wala, your thoughts?
My parting shot is that we always have to remember this is a system. And so one part moving, we need all the parts moving. So the focus on primary care is very, very important. And I think it's something we've been lacking from other regimes. So I want to laud the government for that step in recognizing the role that community health promoters do, and in that breath to also remember that the other systems have to function for everything to run smoothly. Thank you.
Right, it's a system.
Exactly.
All right, I couldn't have said it better myself. Dr. Elizabeth Amakobe Wala, who is a health systems strengthening expert, among other things that she does. Thank you. Thank you for your insight. Linda?
All right. Well, Muga, your parting shot this evening, and perhaps on just how best we can make this whole journey bigger and better.
Oh, first of all, I want to thank our able governor, Sakaja, for just making community health workers, community health promoters being known in Nairobi County, and being noticed that there were people who were just giving out best services to the community, and there was nobody to recognize them. Again, thank to all donors who realized that they should give us something like a jumper to jumpstart us. Because going forward, we can see the government is coming in, and the sustainability of community health is going to be realized soon. I want also to thank the county coordinators, our Madam Judy, who has also stood by us, who has always encouraged us to this extent, where community health promoters can now be called even in a TV station to come and present their issues. You see, it is something that is adding value even to us more. And even the community can realize that we are not just people to talk to them in the community. We are people even to talk even in TV station like other people who are learned.
Right.
So I thank Madam Judy for this. I thank our leadership on the ground who also saw the confidence in us and even brought us to this platform.
Great.
Thanks to all the leadership of the county. They are doing well, and we are assuring them that we are going to maintain health, and there will be no deaths being
reported
within the community if we are there.
Great. Yes, the coordinators. Looks like you've done a good job. Yes, your parting shot.
My parting shot is, remember 100,000 kits were already distributed in our community, in our communities all over the country. And I would urge the county government, remember the community health promoters cannot work in isolation. I call upon the county governments to employ more community health officers and more community health assistants so that these people can always be supervised and be given the needful support and also be capacity built.
Right.
For Nairobians, within the month from October, you'll see the community health volunteers visiting us. Please let's embrace them. Let's give out information. Remember, our health is our responsibility. As the Ministry of Health says, afya yetu jukumu letu. Thank you.
Well put. And of course, now that this is on, I guess it's for us to monitor and mitigate any concerns that would arise until we're able to get this and get it right. It's at this very point that, gentlemen, you'll allow me to join you as we come to a close. Thank you so much, Richard Muga. Richard Muga is a community health provider right here in Nairobi, right? And also the community health service coordinator, or a community health service coordinator right here in Nairobi, right? And that is Georgiadis. That name, Gitonga. Thank you so much for speaking to us this evening, gentlemen, and everybody else that has been part and parcel of this broadcast. The team behind the scenes, always good to make sure that this one then is a success. I think at this very point that we have to come to a close.
Absolutely. Sadly, it's a great conversation. It's a very wide conversation. We cannot claim to have covered everything, but we appreciate our guests for the insights they've shared in the time that we've had. Thank you so much. We also appreciate the teams behind the scenes, the people that are making us look as wonderful as we look, and I do hope we look wonderful to you at home. Thank you so much for the good work that you're doing. May God bless you.
Absolutely. Indeed, the team led by Nick Mavindi, the director, our producer, Tony Mwirigi, and others. We thank you so much, Sound Collins. And I want to just go through some feedback that I've seen, from Mutuku Fred. He says, thanks at TV47 for bringing CHPs and CHOs panel. A good day to hear from the community health workforce. I will sleep a happy CHEW, but I'm told they are now CHA, Community Health Assistants. Thank you so much for your feedback and much more. Of course, on the People's Court, we endeavor to bring you such conversations that impact you. My name is George Maringa, wishing you a good night from Nairobi.
You don't want to tell them that you're Victor Muyakani?
Oh, they know.